Tell us about the training to become specializing in pain management. Most people probably just think opiates or other medications, but what are you actually trained in?
So where I trained was at Rush University in Chicago for fellowship in pain management, and that was a very heavily interventional program. Meaning, it was sort of like being a surgery resident for a year, where we did, a lot of procedural interventions. We were trained in how to do any and all the nerve blocks or sort of injection style procedures, as well as implantable devices or more advanced procedures, things like spinal cord stimulators or devices that deliver pain medication like narcotics to the spine itself, minimally invasive spine surgeries, peripheral nerve stimulation, all kinds of things. And really pain management as a field is going in that direction more and more. We are sort of inching closer to being, for lack of a better term, a surgical specialty than anything else. I don't try to confuse myself with being a surgeon, but we're closer to that than anything else. That's what I was doing this morning. And so, yes, narcotics are part of the equation. Medications in general are part of the equation. My general philosophy with the narcotics is I try to, outside of cancer situations or post-operative surgical pain, I try to be really judicious and stay away from the narcotics as much as possible. But I'll say that there's no black and white. You come in our office and you see some of these people who they don't have cancer, but they've had stem to stern back surgery from the bottom of their skull to the top of their crack. And there's only so much you can do for somebody like that. And so nothing is all or nothing here. My job from a narcotic perspective is to be stewards of it, meaning, use it as appropriately as I can while making sure it's safe, and that we're not doing it without thought. And then I of course, I try to maximize all the non-narcotic therapies as much as possible, whether that's medications, whether that's physical therapy, whether that's some of the procedures I do, whether that's nutrition, right? That's just another wheel or spoke of the wheel, I should say, of what we can do. Acupuncture, chiropractic, any of these things that are maximize benefit while minimizing risk.
Got it. Okay. Have you seen that evolve quite a bit as far as the medications go as you've been practicing in your career?
Yeah, I mean, 10 to 20 years ago, the narcotic sort of landscape was a lot more loose. I wasn't, practicing then, but we're sort of still picking up the pieces from that. If I'm being honest, I think that the pendulum for a minute there and maybe currently still has swung too much in the direction of avoiding narcotics. I am the first one to be very, very cautious with these, but we're in situations now where, because of insurance pressures or pharmacy pressures or other things, where we're almost not giving it to people who probably need it. And so I think that I'm hoping that we're coming back to a bit of a middle ground there, where we use it judiciously and appropriately, but not for every patient or even in the majority of patients. I would say 9 out of 10 or 8 out of 10 of the patients that I see as a new patient, I don't initiate any kind of narcotic therapy ever. It's the folks again that have had a ton of things happen to them, or the cancer circumstances, or the post-operative pain, that I really try to stick to. A lot of patients come to me already taking the narcotics, and so I used to be very heavy-handed about weaning them. I used to say, we're going to get rid of it, no questions asked. Here's the schedule for how we're going to wean it down slowly over time. That might have been a little heavy-handed. Now what I do is I just tell them, look, the goal is to come down on it as much as we can. We're never going to go up on it unless something happens, surgery or some event. And we're going to use all these other tools that we can to sort of facilitate that
Yeah.
as much as possible.
That's well explained. I can't say that I'm too surprised that the pendulum swung so hard back in the other direction with all the negative publicity that those medications got for so long. I told you last time my mom had to deal with cancer and like she was on Oxycontin, and I believe she probably needed the Oxycontin. She went through a lot of pain. So hopefully that does kind of come around to find that new middle ground, like you mentioned. Another thing I wanted to ask you about, since you brought it up, is insurance. How challenging is it to work with insurances on your end as the providing, the doctor providing care?
Incredibly. We are in a landscape right now where the insurance carriers they stand to gain the most from doing as little for our patients as possible. And so their strategy is to put up as many roadblocks as humanly possible to make sure that things don't get approved. And so, I don't want to get too in the weeds politically necessarily, but there are insurance plans out there that I can't do anything for these patients. They would, other than pills, they would much rather me slap them on some narcotics and send them out the door and see them every month, forever and ever. Amen. That is the path of least resistance. There are insurance plans. This just happened today where they will, quote, approve something or not require authorization for something, but the reimbursement for that procedure, even if they approve it, is zero, right? So authorization does not necessarily guarantee payment. They'll tell you that right away, but we're not doing things willy-nilly. We're not doing things without some justification. And it's a shame because we can't do what we think is appropriate for these patients. The cost of the procedures, it continues to get pushed back onto the patient themselves rather than the insurance companies. And the cost of doing business on the physician or the medical practice side only continues to go up for a number of reasons. And so, people sometimes get this impression that you go into medicine sort of for the money in part, and yeah, you make a good living as a physician, but it's not the golden age of medicine anymore, where you can do what you think is appropriate for the patient. There's so many layers of barriers. I got a peer-to-peer phone call, which is the insurance company has a physician on the other end that will call and talk through cases to either approve or deny it based on the criteria. And I got a phone call on Christmas Eve at 7:00. And the reason they did that, in my suspicion, is if I miss the phone call, if I don't pick that phone up, I miss the window to appeal that case, and then it's over. So they're counting on me not picking up the phone on Christmas Eve to not have to approve this procedure.
That's savage.
Yeah, that's the kind of stuff we're dealing with.
That's crazy. I can't imagine. I mean, you got a sense of it there in your reply, but to be the doctor who was trained, who has the experience, who has the people in front of you, there's so much subtle nuance that is not just like, oh, this person's presenting with this, and so follow the flow chart and they have to have this done. Like you have a judgment, and rightfully so, because you know these people and you've seen these situations, and you still don't have the option sometimes of doing what you think is going to be best for people. That would drive me crazy.
Yeah, it's like I say, there's so many layers to this, when it comes down to, the structure of our healthcare system, but to get things done, if I have a patient who's got a fracture in their back, a compression fracture, some of these insurances will make me do 8 weeks of physical therapy. They need to see the endocrinologist, which takes months. Those people are booked out at least 3 months. They've got to fail like 3 other medication options. You got to get an MRI, you got to get a CT scan, you got to do all these things. Meanwhile, so you're looking at 3, 4, 5 months of workup sometimes. And meanwhile, this 85-year-old little lady is in a ton of pain. Wow. Whereas if I find that fracture and the imaging looks reasonable, I can put some cement in that fracture. It's called a kyphoplasty, and I can take care of that in a week.
Wow.
But that's not the way it works.
Wow.
So, I suppose if you think about it, that's another reason that I work so hard on this, meaning the nutrition part is, that doesn't require authorization. It doesn't require a pill or an injection or surgery. And I talk to people about it in terms of probability, meaning it just raises your probability of feeling as best you can. Same thing with smoking, right? Or alcohol for that matter.